Good morning, everyone. Welcome to the session. Today's session will focus on responsive service delivery in shifting health needs. So the objective today is not only to listen to the country experiences, perspectives from our experts, but also we really want to engage you in the audience because we know there are so much wisdom and experience in this room because you know your country context, you know your healthcare system, and you know all the challenges and enablers you have been experiencing. So we want to really engage audience today to have stronger collective wisdom to build up a stronger healthcare system. So to make this session more interactive, first, let's have a few icebreaker. So I want to invite you to scan the QR code to answer where have you traveled from to join us today. So can everyone get your phone out and hopefully you link with the Wi-Fi. Wonderful. We have people from Timor-Leste where I worked before. Great, for people just joining in, please scan the QR code. I also want to introduce myself. So my name is Xiaohui Hou. I'm a senior health economist working for the World Bank. So I'll be today's moderator for this session. It's great to see such a diverse audience today. So let me move to the second question, which is a little bit more challenging. In one word, what does responsive care mean to you? We put some examples there. So if you can think about in one word, what responsive care for you, especially in the context of shifting health needs. That will be same QR code you had before. We have adaptive, we have inclusive, equitable, asset-based, dynamic, equitable, home-based, inclusive, and the quality as well. Wonderful. So I hope after the session, so we're reflecting these features of responsive care, hopefully to get some consensus how we can move on to design and implement responsive care in today's context. Now, it's my pleasure to invite our chair, Feng Zhao, on the stage. Feng is a practice manager of East Asia and the Pacific in World Bank. Welcome, Feng.
I feel I'm already talked too much this morning. How many of you have attended the plenary this morning? Great, thank you. So you already warmed up for this session. So a lot of effort put in organizing this session. We really want to not only have an overview, which Professor Bishia will provide to us on the innovations across the globe on service delivery. This is the area we see most of the innovations. But we also want to share your experiences from different countries. You will hear experience from Asia, Africa, Europe, and beyond. So we call it the lightning talk, right? So I assume you have been working in this field for quite some time. I hope that the exchange will trigger some of your thought and thinking. One reflection I have is, this morning I talk about this is not a new topic. We have been very busy catching up on the changes. If you look at the early phase of our health system transformation in responding to population change, is mainly managing growth. We talk about fertility and family planning services and immunization, keep children safe. And now we're facing an unprecedented new challenge with aging, with climate change, with migration, with urbanization. So I feel we are kind of always passively catching up. But hopefully from here, we will strategically, systematically, and proactively think about how our system will evolve. So I'm very happy about the speaker we have. It takes a lot of effort to get everybody here. So I don't want to say more. We have a long program. I'm very excited about the program and looking forward to listen to you and really let us know your feedback and how we can improve in the future. And welcome to the session. Thank you so much.
Thank you, Feng. And it's now my pleasure to invite Dr. David Bishai. Professor David Bishai is a globally respected health economist and whose research and whose teaching has profoundly changed many of us in terms of how we think about health financing, health economics, and health systems. So now, Dr.
Good morning, everybody. I'm so excited to kick off this great session. It's such a way to integrate what we've been doing here all week and to think about action and solutions because we have cases that have actually been solving this problem. I'm going to be seeing this through my own lens. I'm the director of a school of public health, and there's a pivotal role for the public health workforce. You are actually, whether you know it or not, you're in the public health workforce. What we do in this room is the heart and soul of the practice of public health, and I'll prove it to you. So right now, whoever you were before you walked in the room, now you're a public health practitioner. I'll show it to you. We are coming through this week with a deep learning about our aging populations. We know that these growing elderly cohorts will require integrated care. We know that because of the declining fertility, we have a challenge in getting the workforce that can help this aging population. We have high dependency ratios. The other demographic trend is rapid urbanization and that urban concentration of major pressure, people coming into new slums without services, leaving behind rural sectors where there's abandoned elders and loneliness and difficulty to provide services. All the while, migration has happened and will happen. This century is the century of mass migration, creating disruptions in the social ties of our communities, and we have to be ready for that. And our cases will help illustrate the way forward. So the key drivers to focus on are aging, where the aging population's burden is much more like non-communicable diseases, multimorbidity, obviously mental health aspects of all of this, the need for home and community-based solutions, and then the caregiver's own burden to give care is something that is not easy, and our systems and our cases will discuss how to support the caregiver. The urban infrastructure capacity is being stretched. The rural infrastructure is being stretched. We have new tools. We have new strengths in digital solutions, and we're learning to create culturally diverse services. We also need to make sure we do keep the youth engaged in this entire enterprise, and our cases will help us see how to do that. So not just problems. Now that's 2 slides worth of problems, but I want to show that when we practice public health, we are adaptive to the context. And our social insurance systems are in our hands. We have a legacy of these social insurance financing systems. We want to work with them. We want to show how we create value for our insurance systems by getting better outcomes and keeping people out of long-term care. Well, we have an asset in the family and community caregivers. We need to partner with them, listen to them, see how we can best serve them. We do have a health workforce that is dedicated and wants our help making them have meaningful lives, avoid burnout, and get what they came for, to be meaningful parts of the health enterprise. We have infrastructure that now is growing its digital readiness. We want to embrace that and see how we can get more out of it. We have cultures and social norms, especially in Asia, that honor the elderly and the aged. This is not something that we have to create. We already have thousands of years of wanting to make life good for the senior generation. And we have governance structures that help us. So we want to look to how the glass is really half full, even more than half full with our assets. So the adaptation challenge is to transition to a world where we have to address NCDs and mental health, multimorbidity. We have to worry about our youth populations. What will it be like for them? And we have to attend to vulnerable groups. So in the green box, the key insight is that there will not be one-size-fits-all solutions. There never have been, which is why we have multiple case studies from multiple areas adapting to their needs, adapting to their strengths. And every case will show how it wasn't a one-size-fits-all. It was adapting. In fact, adapting locally is the one-size-fits-all. Notice what you have and what you need. So that's really where we have to be. And at the bottom of the slide, we have to keep our eye on persistent inequities. That's always the undercurrent. Keep our eye on the vulnerable, and that's our urgent need for attention. All right, so primary health care. In my dictionary, I have the WHO dictionary, and so when I say primary health care, I mean primary health care and public health practice, the way it was defined in 1978 in Alma Ata. So primary health care with the WHO version, it means the systematic process of assessing population needs and identifying local assets, and then creating policies that enable the health systems to adapt, both needs and assets. The public health practice that we are doing, because you're all public health workers right now, we are going to show the needs. We're going to map the assets. What are our strengths? What is locally good about what we can offer? And participatory creation of policy, as well as expert-led policy. But if we really say the experts know all the answers, we're going to miss something. We're going to miss a lot of that local asset strength. So participatory policy creation, and then enable that adaptation, because we've been partnering all along. That's what we're gathered here to do. So that public health workforce that does what I just said, they need training in cases just like this. If I, as a public health professor, say, okay, here's biostatistics 101, this is regression, this is factor analysis, this is your p-value, they don't know how to do community adaptation. I need cases like this, and I'm so glad that we are gathering those cases so that not just math and statistics, but forming partnerships and adapting and communicating and building trust. Those are the right skills. So we need that full toolkit. Obviously, they need data access, both quantitative and qualitative, and then the skill of advocacy, knowing who the stakeholders are, knowing what moves them. Is it finance? Is it equity? Is it how to take care of burning needs in their waiting rooms of their emergency department? And then to form the partnerships. So enabling service delivery innovation, which is what we're seeing here, we want to have person-centered care because we've formed partnerships with the people that we serve. We want to find ways to create community and home-based services. We cannot stay in the clinics and solve this problem. Primary care has always been a coordination hub, not the end destination. It is the hub where community services start. Community health workers come out of that hub and serve the people in their homes. Tailoring services based on assets and needs, knowing what those assets are. So that workforce transformation is by showing our workers these tools of getting out of their clinics, going out to the community, forming partnerships. I need my medical students, my nurses, my public health trainees to go out to the community to see how these cases work. And perhaps we can find more ways to do that. So we have to have financing for all of this. I hope we ask our presenters, how did they pay for this? And how did they show that they were saving money to the health system when they did this? Because if you show the hospitals, we are not costly, we are saving you money, then financing can be unlocked. We'll talk about digital health and about community co-design. So the key to this session is what I say is we are the public health workforce today. We are doing this integrative work, forming partner-based solutions. We're mobilizing stakeholders, and we're going to monitor our implementation so that we can continuously improve it. So I won't take time from the case studies. Just briefly, you're going to see 6 places: European Union, Singapore, and Japan. You're going to see Kenya and Ethiopia, Sri Lanka, and Malaysia. And in each case, you will be seeing the demographic context, rapid aging, different assets in each case, and sometimes they use task shifting. Sometimes they use a community-based aging in place. You'll see social prescribing today. You'll see home nursing in Japan, and you'll see short stay services and team-based approaches. In Kenya and Ethiopia, you'll see community health workers, always one of their top strengths. How did we change community health workers into taking care of aging populations? In Sri Lanka, long legacy of participatory, community-based design of programs. And Sri Lanka will show us that. And in Malaysia, we'll see how they're adapting technology into this space. So lots to come up. Cross-cutting themes that you'll see, there'll be digital health cross-cutting. They'll be helping to adapt the workforce cross-cutting. Financing reforms. You will see equity, and you want to ask about that during our Q&A. Governance and accountability is a cross-cutting theme. Each of these cases had to solve this problem, and each case had to get communities engaged. So what will we achieve together? We're going to see the cases, draw lessons together, share our understanding together, see how we can innovate. How can we go home from Bangkok and take best use of these recommendations? So let's learn from each other. I'm looking forward to this wonderful time for sharing. Thank you so much.
Thank you, Professor Bishai. And so we are going to have a series country case presentations, the lightning talk. So before that, I want to remind the audience to scan another QR code. So this QR code will enable you to submit questions starting from now till the end of the lightning talk. And you can submit multiple questions. So we'll collect all those questions, but there is also a chance for you to ask in person later on behind the mic. So without further ado, let me first invite our first speaker, Dr. Tan Xiang Koo, who's the Associate Professor and the CEO of Singapore General Hospital. Over to you.
Good morning. I suspect many of us in this room are facing the same kind of reality. Our population is definitely aging, more complex comorbidities and chronic illnesses. Yet, at the same time, across all our health systems, we are seeing that we are remaining largely unchanged. We're still very acute care-based or centric, hospital-based, and we are still very much illness-focused. And it is perhaps not surprising that the health system is under so much stress. And what we have learned is that this is not simply a capacity problem. We can add beds, staff, funding, and we have done all of that. Yet the reprieve are often very, very brief, and the pressure returns very quickly. And what seems to matter most is about care design and care alignment. For us, responsiveness is increasingly not about just responding sooner, but responding closer to the patient and responding with more precision, especially those with complex needs. I'm going to give maybe 4 examples and some of the lessons learned in Singapore and at Singapore General Hospital. To put in context, Singapore General Hospital is the largest public health institution, about 2,200 beds. We are known for taking care of patients with very complex tertiary needs. But increasingly, we understand that episodic care is no longer sufficient for aging populations with multiple conditions. So one response that we had is to set up, within the acute hospital setting, a division of population health and integrated care. And the intention is simple. we wanted to understand our population better. We want to segmentize risk, understand the trajectory. We want to be able to coordinate care across the hospitals, primary care settings, as well as the social settings. So we'll give you some examples of this. The division have put in place-based multidisciplinary teams such as community health post, and this is run out of the hospital, and urgent response team that attend to time-sensitive medical needs that can still be managed in the comfort of the patient's own home. Without these teams, the patients will be admitted to the hospitals. One interesting initiative that we just launched a few days ago is this TriGen initiatives. 3 generations of folks involved in this. The youth volunteer their time and energy in a program curated by healthcare professionals and coached and mentored by healthcare professionals, the 2nd generation, providing service needs to seniors in the geriatric ward admitted for delirium and cognitive impairment. Now, the pilot that we have done yield very promising results. For the elderly, the length of stay has reduced from an average of 14 days by a reduction of about 2.87 days. Interestingly, they became more digitally savvy. They start to be more comfortable using their smartphone because they are interacting with the youth. And importantly, when they are discharged from the hospitals, the compliance to follow up in a GP clinic increased from 42% to 84%. For the youth, they are energized because what they do is purposeful and they can see the impact. And we hope one day they will join our profession. And for the healthcare workers, they are very, very happy with this because they see that their patients are provided a service that they have no bandwidth to provide. So win, win, win across the 3 generations. It is measures, proactive measures like that, that we managed to reduce our long stays in the hospital by about 15% within 1 year. And that adds to be almost a 27 million cost avoidance in our context. Another example is that hospital cannot and probably should not be the default site of care. For selected patients, we now offer inpatient level care that is within the comfort of the home through multidisciplinary teams, telemedicine, remote monitoring. Over a span of about 18 months, with a pilot 40 beds, we managed a bed day saving of more than 8,000. And importantly, that means that we can admit 1,350 patients more who truly, truly require inpatient care. The third example or lessons that we learned is how can we, beyond reacting well, how to anticipate the problem sooner. Most of the health systems, understandably, are created to respond when patient deteriorates. What we are now learning is to anticipate earlier so that we can sustain health rather than repeatedly managing illness. And one such tool that we have is Pensive AI. This is developed in-house in Singapore General Hospital. It's a 5-minute self-administered digital drawing test that uses AI to detect early cognitive impairment. It achieved a 93% accuracy, which is comparable to gold standard tests, which often require 45 minutes to an hour. And importantly, it is less dependent on literacy and language preferences. It is scalable. And it allows us to have early conversation and early intervention. So the shift is really beyond just reacting well, but we want to anticipate this earlier. And maybe the fourth examples and lesson is truly about aligning incentives. One challenge we have previously encountered is that service redesign is clearly not sufficient. Because if financial incentives continue to reward episodic volume-based care, it is very, very difficult to sustain population health approaches. So 2024, under Healthier SG healthcare reform, we also reform our financing model. It is now capitation model, which then allow us to prioritize continuity and prevention care. It allows hospitals like us to invest in division of population health and integrated care. Because alignment matters, systems tend to go in the direction of what we pay for. Now, putting all of this together, what does it all mean? I'm just going to use a kind of familiar patient, 75-year-old gentleman with chronic obstructive lung diseases, admitted to the hospital with chest infections. We have all seen this kind of patient before, comorbidity of heart failure, diabetes, mild cognitive impairment. In the past, we give them antibiotics. When the infection resolves, we send them home, and they often come back, and they do come back. Now, we identify this risk. We can detect the problem earlier. We are able to let them recover at home through hospital at home scheme with the support. And we practice social prescription through collaboration with our community partners and keeping the patient healthier and longer within the community. Better functional recovery, more confidence, and fewer readmissions. So, in closing, we know that health needs will continue to shift and change. That is clear. From our experience, responsiveness is less about a single program, a technology. It is more about alignment of care. It is about how we design the care, where we deliver it, how we anticipate the risk, and how we pay for the care. It means we take more time looking beyond the boundaries instead of working just within the institution. It also means that we should be willing to invest upstream, even when the return on investment may not be certain. And we need to be willing to create space for a new model of care by de-implementing outdated model of care. But last but not least, that requires us to be a learning health system, constantly innovating, constantly implementing, constantly evaluating. None of us have a full suite solutions, and it is through forums like that that we share and we learn. And I think as we do this, we really increase our chance that our system can move from reacting to illness to sustaining health. I believe this is the task before us. Thank you.
Thank you so much. Thank you so much, Dr. Tan. We learned so much today in the plenary session of the responsive to population needs. But needs are not just the population, it's also family needs, patient needs. So how we can build up the care of the model and then integrate them at the system level. So that's something I hope we can get more reflections later from the audience. Now, we are from Singapore to Malaysia. So let me invite Dr. Tengku Azhar Hamid, Chairman of the Board Private Pension Administrator in Malaysia. Welcome, Dr. Azhar.
Let me tell you who is really taking care of older person in Malaysia. It is a 43-year-old woman, a 43-year-old daughter who wakes up 5 a.m. every day in the morning to bathe the father. And later on, she already has 2 hours of working before. Oh, okay. Sorry. Okay. I will not repeat that then. I'll change to another one. Okay. It is a wife who in her late 60s is taking care of her demented husband who wakes up in the middle of the night, and she has not been resting well for the last 3 years, sleeping well for the last 3 years, because he wakes up in the middle of the morning, at night, going somewhere, and she has to listen to his movement because she's afraid that he will fall. So this is the kind of situation that we have in Malaysia, and also a son who is lifting the mother from the bed to the wheelchair, and he himself in the process is hurting his back, but he has to do it every day because no one else is available. So these are the situations that we are facing in Malaysia. And if they are not nurses, they are not trained caregivers, they are also not paid. They are daughters, husbands, sons and wife, that they are the backbone of Malaysia's long-term care system. In Malaysia, 5.1% of adults are doing this care right now. They are women, majority of it. They are sandwich generation, and they spend about 24.5 hours a week in caring. And only 21% of them are trained. Caregivers is not just a duty, it is also a cultural expectation. But at the same time, caregiving is physically drained in ways many of people do not really realize. It is lifting a parent from the bed to the wheelchair every morning, waking up multiple times at night because you are afraid that they might fall. And many caregivers do this without many years for it, and they don't even until they feel the pain. It is also about emotionally exhausting. It is the availability of people to look after you, and also you don't really share your your emotion with others because you feel that if you do that, then you fail in your duty as a daughter, as a son, as a wife, and as partners. So this is where the situation is in the current day. So in the sense that at the same time, we also do not have financial system yet in place. So this comes out of the children or the informal caregivers looking at expenditures for medicine. There are also maybe a declined promotion because they cannot leave the older person, and also at the same time, where will they get help? So if you look at in Malaysia, we have many services that is available, but the critical part is that these services are not integrated. They are fragmented, and in the sense that a lot of people, a lot of caregivers cannot navigate where the services are. So in the sense that we really need to look at how we can develop a continuous care framework so that it has easy access to the older people. And in a sense, and in this situation, we also have government support for this in terms of the availability of support, but at the same time, we look at how can we sustain this kind of system because we have not really developed the continuum of care. So then we look at caregivers are not just supporting the system, caregivers are the system. In Malaysia, for example, if you look at the problem is not about absence of support, it is a problem of fragmented. Therefore, it is difficult to manage. In that aspect, then, I would turn to how do we look at innovation, and there are a lot already when I showed in the previous slide, but innovation has important impact on improving confidence and caregiving, reduce emotions, and also better work care balance, and enhance quality of life, quality of care at home. But the lessons learned from Malaysia is that informal care remains the backbone of LCT. Innovation works best when it complements family care, not replaced it. It is affordable and accessible, respect cultural values, starts with self-care and the life course. And in future, we need to look at recognizing the informal caregivers, especially supporting unpaid role through training and respite. And we need to integrate digital health, LTC, health and social care system seamlessly. And we should expand the caregiver allowances and respites. For this to happen, we need to have a stronger partnership between government, private sectors, NGOs, families, and community. And supporting home-based informal care through innovation is essential for building a sustainable and inclusive long-term care system in Malaysia. Thank you.
Thank you so much, Dr. Aizang. So now we heard home-based care by informal care workers in Malaysia. We now come to Japan, one of the most aged countries in the world. So it's my pleasure to invite Dr. Kisuki Shumiju, the Chief of Family Medicine at Izu Health and Medical Center, together with Dr. Ju Sasaki, founder and CEO of Yushukai Medical Corporation. Together, they will present the Japan's case. Over to you.
When I started working as a general physician on the Izu Peninsula, many older people and their families were anxious and uncertain about their future. Suffering from various chronic conditions, they lost their physical strength gradually and found it increasingly difficult to visit hospitals. And when their condition worsened, they often had to call an ambulance. But even then, it was difficult to find a hospital to accept them. And even when they were admitted to the hospital, their hospital stays were often very short, as they lost their physical strength, daily life, and a regular visit to hospital became increasingly difficult. So many older people reluctantly chose to enter long-term care facilities. At that time, there were very few doctors providing home-based medical care in this region. Since I began providing home-based medical care, many patients have been referred to me and my team. So today I would like to introduce two of these patients and illustrate how home-based medical care is supporting safer, more secure, and high-quality living for older patients. First, Yoshiko, a 75-year-old woman. She noticed a cough and she visited a hospital where she was diagnosed with stage 4 lung cancer. At first, she was admitted to the hospital and received treatment, but her condition worsened quickly. And she became bedridden and was given just 1 month to live. And when asked where she wished to spend her remaining time, she chose to stay at home. After her discharge, home-based medical care was initiated. I visited her home once a week to adjust her medications and provided guidance to nurses regarding to her drip infusion therapy. And nurses visited daily to administer IV drips, perform sputum suctioning, and support families in caregiving. And home helpers also visited daily to assist with meals, change diapers, and provide personal hygiene care. And all service providers shared information closely to tailor care to her condition, while also offering emotional supports to her and her family. She was able to enjoy her life at home for 1 month, and she passed away peacefully surrounded by her loved ones. Next, Yorie, 93-year-old man with dementia. He lived with his son and suffered from various chronic conditions, including hypertension, diabetes, COPD, and heart failure. He had been seeing doctors in various specialties at a university hospital, including respiratory medicine, cardiology, and psychiatry. However, each doctor focused mainly on their own specialties without fully considering his overall condition or daily living. Repeated hospitalizations due to worsening heart failure gradually weakened him and made it difficult to regularly visit hospitals. At that time, home-based medical care was initiated. Nurses and I began visiting his home regularly, and we soon discovered that he was not taking his medications properly due to cognitive decline. And additionally, he was taking high-salt diet, which was also contributing his worsening heart failure. So by combining daycare services and short-stay services, we were able to better manage his medications and diet. And through close information sharing among multiple professionals, we could detect early signs of heart failure exacerbation and promptly adjusted his medications. In the 2 years since beginning of home-based medical care, he has continued living at home without a single hospitalization. In this way, home-based medical care allows doctors and nurses to be available around the clock, even when patients become unwell, enabling testing, examinations, and treatments to be provided at home. Furthermore, by combining long-term care services, working closely together with multiple professionals, and paying attention to all aspects of daily life, we can support the daily safe and secure living of older patients. Japan is responding to its super-aged society by promoting this home-based medical care and integrated, comprehensive, and multi-professional care. Next speaker, Dr. Sasaki, will take a broader macro-level perspective and explain how Japan is responding to issues, aging-related issues. Thank you for listening.
Now, let me invite Dr. Sasaki on the stage to continue the journey of Japan, but at much broader, higher level.
Hi, good morning, everyone. I'm Dr. Jun Sasaki from Tokyo, and I'm also a home medical care provider. And so I manage a medical company named Yushokai. The Yushokai is one of the most largest home healthcare provider in Japan. We operate 25 clinics with 200 doctors and 400 staff members. Together, we provide 24/7 home medical care for 10,000 patients at any given time. Our field of practice ranges from major metropolitan areas to small remote islands. The circumstances vary greatly, but the fundamental needs of patients do not change. Even with illness or disorders, people want to continue living peacefully in their own way until the very end. First, I'd like to share 3 numbers: 30, 10, and 50. Japan's aging ratio is currently 30%, the highest in the world. What we call advanced aging is becoming a big issue. Within the elderly population itself, aging is accelerating. By 2040, people aged over 80 will account for more than 10% of total population. And now, Japan's total national medical expenditure has reached 48 trillion yen, and 50% is consumed by people over 75. Our current healthcare system is not sustainable and it is not optimized for the hyper-aging society. In Japan, emergency ambulance transportation among elderly are rapidly increasing, and 65% of them involve elderly patients. As you can see, only the number of transportation among aged over 75 continue to rise. However, 50% of elderly patients transported by the ambulance have mild conditions and do not require hospitalization. This is putting pressure on our emergency medical system. One major factor behind this is increase in the elderly living alone. In Japan, young families raising children are decreasing year by year, while single elderly and elderly couples are increasing. In addition, Japan does not have primary care registration system. Many elderly do not have a GP, and even if they do, doctors cannot respond 24/7. With the decline capacity of households to provide care, especially for elderly, calling an ambulance often becomes the only option. Dependence on hospitalization is also remarkable. Currently, in Japan, 67% of inpatients in acute care hospitals are over aged 75. 34% are aged over 85. This age-related increase in hospital dependence is a major cause of rising healthcare costs. The reason for hospitalization among elderly changed significantly after the age of 85. Among younger elderly patients, hospitalization are often due to stroke, cardiovascular disease, or cancer. In contrast, among those aged over 85, it's due to frail-related conditions. This slide shows the cause of emergency hospitalization among the elderly we care for. Hospitalization due to CVDs or cancer are relatively small. Most admissions are due to infection and fractures. The outcome of hospitalization for those conditions are poor. For elderly hospitalization with pneumonia, 30% die in the hospitals. Survivors experience an average worsening of 1.7 care level at discharge. In Japan, care needs are classified into 5 levels. One hospitalization often means dropping almost 2 steps on their levels. A similar trend is observed with fractures. Many people believe that hospitalization is safer, but this is not true, especially for elderly patients. Hospital care is highly invasive for elderly. Younger people can tolerate it, but many elderly lose their physical and cognitive functions. It is known that just 10 days of hospitalization can result in muscle loss equivalent to 7 years of aging. As a result, continued life at home becomes difficult. In fact, among our patients who are hospitalized, 1/3 are unable to return home. Living peacefully until the very end is not easy. Most of us experience a major illness along the way and comes to require care. After that, we experience repeated illness, repeated hospitalization, and a stepwise decline in physical function, like walking down a staircase. As a result, many people die in hospitals. In Japan, 80% of the people say they wish to spend their final days at home, but only 20% are able to do so. Moreover, among those who die at home, 30% are found dead and handled by police. Due to the increase in elderly people living alone, so-called lonely deaths are increasing every year. In Tokyo alone, every year, over 13,000 deaths are investigated by the police. Many elderly repeatedly call ambulance, repeatedly hospitalized, and finally die in hospitals. The mission of home health care is change this trajectory. For frail patients, we prevent sudden deterioration, and we provide 24/7 response and prevent ambulance and hospitalization. For patients who are hospitalized, we support early discharge, recovery after discharge, and avoid readmission, reducing dependence on hospitalization. Ultimately, patients can spend their final days peacefully at home. We regularly visit patient home and provide continuous health management. We focus less on aggressive treatment and more on living well with illness and disability by adjusting medications and providing nutrition care, oral care, dementia care, and palliative care, and family care, and so on. Some patients require medical devices. We support the safe use of ventilation, tubal feeding, and other devices. Just a moment. Other devices at home. In emergencies, we respond 24/7. We handle over 30,000 emergency responses per year. Of those, 30,000 are managed by telemedicine. Just a moment. 30,000 are managed by telemedicine, and 70,000 involve urgent doctor's visit. As a result, it is estimated that ambulance transport of elderly over 75 by Tokyo Metropolitan Fire Department have been reduced by 12%. And 80% of so-called acute deterioration can be diagnosed at home. Portable devices advanced significantly. We can minimize ambulance and hospitalization through home-based treatment. And treatment of infectious disease and blood transfusion and palliative care with opioids. These procedures can be performed safely at home. Sometimes we use remote monitoring. As a result, dependence on hospitalization decreases. After initiating home health care, our patient reduced hospitalization by an average of 30 days per person per year. It means a reduction of $10,000 per patient per year in hospitalization cost. She's registered dietitian. In Japan, malnutrition is recognized as a key to prevent frail-related conditions among elderly. And he is a dentist on our team. He is responsible for assessment of swallowing and eating rehabilitation. In Japan, multi-professionals visit patient homes and providing integrated care. All of these are covered by medical insurance and long-term care insurances. Less sudden deterioration, less hospitalization, and as a result, 72% of our patients live peacefully at home until the end. By providing comprehensive multidisciplinary home care, it is possible to sudden change. It's possible to support the final stage of life without dependence on acute or inpatient care. This is highly meaningful both the patient's quality of life for the sustainability of social security system. Home health care in Japan is not limited to so-called hospital at home during acute phases. It includes preventing deterioration through continuous health management and providing 24/7 response to prevent hospitalization, support early discharge when hospitalization is necessary, and minimizing functional decline, and providing advanced care planning and palliative care to support peaceful living until the end. To achieve this, we combine regular home visit with 24/7 response as needed. By delivering the minimum necessary amount of medical care, we maximize patient quality of life Those are the three principles Japanese Long-Term Care Insurance Act: continuity of daily life, respect for choice, and utilization of remaining abilities. These are also the ultimate goal of all medical care. Appropriate use of medical responses and high quality of life are not mutually exclusive. I believe home health care is a key to achieve both. Thank you.
Thank you so much, Dr. Sasaki. Now, let's move to Sri Lanka. Let me introduce Dr. Shiromi Madhuwagi, Public Health Specialist, Sri Lanka Ministry of Health.
Good morning. Thank you very much for the kind introduction. And Sri Lanka is an island in the Indian Ocean with a 22 million of population. So out of that 22 million, we have 16% of elderly population and 8.5% of persons with disabilities. So projections for 2040 will be 25%. So a country like us, the rate of increasing elderly population is very much higher. And also when it comes to this increasing elderly population, they encounter, without any exception to the other countries, a lot of challenges. Could be health, social, and financial also. So all these, when we analyze those challenges, what we see is these are interconnected. So when it comes to the providing services in an effective way and also the results-based outcomes, so what we really wanted is integration. And when it comes to this service provision, what we really realized was turning medical model to the social model is an essential part. And also with the parts or the stages of providing it when it comes to elderly persons and their family members and the caregivers, and then different levels of service provision, and also under the age-friendly settings, and also covered with policies. So when it comes to the integration, we identified how we are going to do it in a prioritized, systematic, or stage-wise or phased manner. So we know that we want palliative care, end-of-life care, intermediate care, all together in one inclusive environment. But at once, a country like middle income range, to do it at once is so difficult for us. So we have identified the priorities. So the priority identification was based on community voices. That's what we did. So that's another key sharing experience that we want to highlight. So giving priority for the community choices as well. And also with culture adaptations and culture appropriateness as well. And also when it comes to the primary health care, that was the key thing that we highlighted, reforms and reintegration of all these things. So in primary health care, we identified a wellness center which is very close to the persons of elderly as well as the persons with disabilities, where these wellness centers are identified among them in a empaneled population of 5,000 to 7,000, which is a very limited amount of people. And then from that wellness center, they entered into the primary healthcare institutions there, and then secondary, tertiary, stepwise manner. So another experience what we're sharing is, so each and every these points of care points, we have identified the pathways, what we need to do, and then how we are going to refer the patient or the client to the next stage, and what are the guidelines and what are the pathways for that. So which enabled us to make a lot of cost-cutting and very effective way of providing services. And also when it comes to the human resources, so during past years, we have identified the migration rates in my countries has gone up. So young people have migrated in many numbers. So we are lacking human resources or the workforce. So what we really wanted or what we thought was getting maximum or utilizing what is existing at the ground level under multidisciplinary team approach. So in the ground, especially in the primary health care, so the health workforce is combined with the social side workforce as well. So we have elder rights promotion officers, social service officers. They are working together with health workforce of the medical officer of health and the health team at the ground level. So we combined those together and then got the maximum out of their services. And also, at the primary health care, so we have identified what is needed for them. And then in the UN Decade of Healthy Aging, integrated care for older persons was identified. So all 6 domains were implemented there under ICOPE clinics. So, but it's not only health. What we did was we adapted that all these manuals and all this concept to Sri Lankan culture. And also we integrated that all health domains of screening parts with the other social side of activities as well. But when you see it at a glance, it may be very simple, but when we are going to operate it, it's very comprehensive and it's very difficult because you need to think of culture, behavior, attitudes, and all together to implement these activities. So what we really identified was we need to have very clear advocacy and awareness among all stakeholders. Then only this journey became very easy for us. So also, it's a life course approach. So we utilized our younger generations as well as young old group, especially when it comes to caregiving, because we are lacking of workforce. So the young elderly, they looked after old group of elderly as well. And also, this is the picture. It may be a little bit of comprehensive and a little bit of complicated, but what I talked up to now is picturized here. So preventive health side, curative health side, social, we all tried to connect together in a comprehensive picture at the primary health care because we understood it's a very innovative as well as cost-cutting intervention for country like us. And also which is overall covered with all the policies and especially very recently we have revised our national policy for elderly with 10 core areas. So the specialty was this policy based on the qualitative part which came up from the community. They highlighted certain areas. So as a practice from ages and ages, we are just talking about rights and protection of elders. But the novelties of these things we have forgotten when we are developing policies. But this time we have come out with all these problems, and because the key hidden factor for that was community voice, listening to the community voices. And also in par with our policy, last year, November, we had 78th session of the WHO Regional Committee, and Colombo Declaration was published. So the Colombo Declaration also we developed based on the participatory dialogue of the older persons. That every time when we get a chance, we gave the maximum highlight to the community voices. That is a real productive thing for the way forward. And also we have more than 11,000 of elderly committees and elderly day centers in the ground level. So that is also another way forward action that we are planning to upgrade those things for getting all these benefits for our people. And also another project is coming up and it's progressing. It's the community empowerment program under our new government. And that is a bottom-up approach, and the decisions were taken by the community and under the community development councils. And then it will be given to the hierarchy, the service providers. Then they will prioritize what to do first and second and like that. So that is another thing that we are looking for, to have the collaborative effect of community empowerment programs. So under that, all these things will be addressed, and hope that we will be having the right-based approach to the person-centered integrated care. Thank you.
Thank you so much, Dr. Madhuwagi. So we've heard experience from Asia now. Now let's move to the continent of Africa, where the population generally much younger. It's my pleasure to invite Dr. Mohamed Al-Douma, Head of Health Unit from IGAD, Intergovernmental Authority on Development Secretariat, who will share experience from Africa region.
Thank you. Thank you very much, and very glad to have the opportunity to share Africa. But I think, and thank for the organizer, PMAC is a very good platform for sharing. It's good that, especially without sharing of experience, and also we, like in Africa, we don't need to reinvent the wheel. So if something not working here, we can now move on and have a new innovation for that. So imagine if you are an elderly, 70 years old in Africa, in a fragmented system, fragmented care, and you have a rising health needs. Our health system is really affected. My boss usually say we have a combination of 3 C's. Conflicts. I am working with 8 countries. 4 of them, they have ongoing conflicts, and it is implication on the health system. The other C is the climate. Our countries, they are in East and Horn of Africa. And this is, if you look at the climate change, it is one of the most affected globally with the climate change. The third C is COVID. Still, we are grappling with post-COVID implication on the health system. So imagine all this, in addition to what Prof. Chris yesterday mentioned, not only double burden of the disease, we have a triple burden of the disease because of the implication of the climate and environment, in addition to the communicable and non-communicable diseases. Who knows this? WHO. Who is in WHO? Nobody? The first? Yeah. Yes, onchocercasis. And the second one in World Bank, yeah? This is the lobby of the World Bank. When I was like 15 years ago, working clinician, now public health maybe, I was in the area in my country. I am originally from Sudan. And they have this, and imagine it takes 10 years to get blind. It destroys the optic nerve. So the system now, even overburdened with the neglected tropical disease, the NCDs. So most of the Africa, this disease, I don't think in Asia, maybe Yemen in the corner there, but also I think in Latin America, maybe Venezuela and part of the Brazil. But we have several neglected tropical disease and people getting old also, and that add burden to the system. And this in addition to those numbers. In the morning, they mentioned by end of the day, we will have 40% of the population globally. But with the rising age, and you can see by, I think it's not one. By 2050, we'll have the largest population over 60 globally. So imagine the system not ready. Second, it is still dealing with the youth population. We have currently 60% of the population they are youth. And also, dealing with the acute problems, in addition to other communicable and non-communicable problems. So we really suffer. Within this suffering, we have some examples. I think in this resource, limited resource setting, it is a good hope for us. The first example, Kenya. Community health system. Let me stand here, maybe. Kenya, they have the health system. How I go with this? Yeah. So they have the community health system. First, Kenya, they work on the strategies and framework. They have the strategy for community health. They have a strategy on healthy aging and older person strategy. And they have also NCD, prevention and control strategy. And they train community health workers, and they provide a one-year program and a package from the primary health care. And the most important, they are part of the system. They provide salary for them. And they distribute them in a health post to serve 5,000 population. So they became very close to the community. They take care of elderly. They take care of the community. And they provide preventive, promotive, and basic care services. And also refer if they have conditions that beyond their skills. So Kenya is a lower middle income country. They were able to launch this program, and it is working now. And we hope that that will be something that we take it forward. Ethiopia, they also took a primary health strategy, and they invented a program. They call it Health Extension Program. Ethiopia, when you compare, it is a very large country. It's 1.1 million square kilometer, and the population 120 million. So they invented the Health Extension Program, and they train the health extension workers, a one-year program also, and they formally make them part of the health, and the Minister of Health, they provide salary for the health extension program. The difference in Ethiopia, it is a home-based services. It is not a facility base. So they visited the families and household. They provide also preventive, promotive, and also basic care. And through the task sheeting, they train them on 18 packages of primary health care. So they provide the support, they provide the screening, they screen for diabetes, for hypertension, and also they provide adherence support for the chronic people on chronic medication. And if someone needs health, they have the ability to refer to nearby health facility. So those are two examples, I think, and we are in the process to scale this to the other country, two countries. They are doing very well, and we think that this can be scalable with more training, financing, and maybe sharing of information, because also we have platform like this for countries to share information so that other countries, they can employ the same way. In Africa, we think the most thing that we rely on it is the traditional system for the community and family. It's still the elderly, they are staying with the family. I don't remember I have seen a nursing home or a daycare in all our countries. In my country, there was one, but limited maybe to some people who had no families or they migrated their children. So we are relying on this. So our health system can help in training those caregivers, provide them with information, awareness, and also linking, and thank for the digital era now, where there is apps where we can link them with the country, with the health facilities in the country, so that we can link the elderly with the service. The most important problem or challenge that we have, it is the social protection program. Most of, even those two countries, they don't have health insurance program. Ethiopia, they don't have health insurance program. Kenya, they have hospital-based. They start now to expand it to the community, but they are relying on the public service. But I think in the future, with increasing age, we need a social protection program that can help this. Let me stop here. Thank you very much.
Thank you, thank you, Dr. Al-Duma, for sharing not just the challenges, the 3C challenges, crisis, climate, communicable disease, and non-communicable disease in Africa region, but also the innovations happening in the region. We already see some questions submitted through the QR code, so I invite you to continue submit through the QR code. Now, let me invite our last speaker, my colleague, Dr. Anna Kozel, Senior Health Specialist from the World Bank. She's going to conclude this series of lightning talk.
Good morning, everyone. Am I the only one who's cold? Thank you. Feel much better already. I'm the last speaker. I'll be very brief. I'll not be repeating what have been already said. There are plenty of amazing stories and examples, and there are many similar ones that I could share from Europe. However, I'll try to talk about something that I think we might want to also consider for the upcoming years. There are 3 things I want to remember from my presentation. Number 1, there is a sense of urgency that we all need to consider when we look at aging and opportunities in the changing environment. I'll show you why. Number 2, culture matters, and the way we actually behave and what we believe and what we want as societies also matters. That can influence incredibly what kind of uptake of any reform you'll have. And number three, private sector can help. There was no discussion today. I haven't heard much, except I think Japan, about private sector involvement, and that's a huge opportunity that we can all see in the coming years. How do I do that? Okay. Move on. I was born in the late 70s, so I'm very young. And when I was born in Poland, thank you. When I was born in Poland, less than 1 person per 10 was 65 plus. Now it's doubled. And when I'll be 80 or 90, if I'm lucky enough, there will be 33% of people 65 plus, and it will be the largest population group across the country. And it's the case for most of the European countries. What does it mean? It will mean that this conference and this audience population or age may be different. We might see more of us at the later stage of life, or less younger people. But it also means, for example, small thing like this presentation is specifically made in black or white colors or sharp contrasting colors, because this is the EU regulation for all the public documents, that they need to be contrasting so elderly people can read them better. There are small changes and big changes we need to consider. 5 lessons from Europe, and this is a subjective view, so it's a summary of many other examples we can have. Number 1, start early and start broadly. When I was teenager, I think, my grandmother had a stroke, and that ended up her being paralyzed for remaining 3 years of her life, which at the end of the day meant that my mom, who was at that time full-time teacher with family, daughters and kind of life to run, had to completely change their life to take care of my grandmother without no support, no knowledge, no formal system how to do that. Lucky enough, my mom has 3 sisters and 2 daughters. So we all took turns to make sure that our grandmother is being taken care of. However, 30 years later, I'm at my mom's age, and if my mom has a stroke or something happens to her, I'm going to be in the same situation. So the system did not follow with the speed and the magnitude of challenges as it should have. We are taking it too slow and too easy. In 2022, the World Bank did a behavioral study in Poland when we were looking at different aspects of aging, including what do we think and what do we actually do related to aging. And we asked respondents, which were adult population, whether they ever discussed anything related to aging with their families. And apparently 76% of people never discussed this. And that leads me to point number 2, or lesson number 2, culture norms matter. We all assume that it's a family job to take care of us when we get old. But most of us very rarely or never discuss this with our families. How does this work? How it's supposed to work? When we also asked respondents about whether they think they will need care when they get old, most of them, over 70%, also said, no, I'm going to be fine. I don't need any care, and I probably won't need any care as I move ahead in life. This is sort of comparison. We can compare it also to OECD data, showing that around 25% of adults at some point of their life will require some sort of care, and around 5% of us will require significant amount of care and long-term care support. So at one side, we do not discuss this with the family. Another element is we expect this we expect that it will be okay, but some of us may not. And the systems need to adopt much faster than we anticipate, because life is surprising, as we all know. Also, this is something that is assumed by culture, that this is women's job, right? We already discussed it. We've heard it from Malaysia. We have heard it from other countries. And it is women's job. It's almost universally across the world. This is women's job, where we are taking care of our children, our parents, our family members. Example from Greece, 40% of women at some point of their life are care providers, and compared to only 29% of men. And this is across all European countries, where women are the one providing informal and actually formal care. We've heard a lot also about chronic diseases and the change of service delivery models. Two examples. When I was talking, I think we went to Finland at some point, actually with Fong, and we were discussing the way service delivery models change in Finland. And the doctor was saying, well, in the 70s or 80s, when a patient with a heart attack would come to my hospital, we would keep them for 2 to 3 weeks. Now we are discharging them after 3 or 4 days because that's the most efficient way of providing care. Women in Poland live on average 20 years with some sort of chronic disease, most frequently at least 2 and more. This is huge change in the way we deliver care because it takes 20 years, it costs much more, and it's much more complicated, as we already seen today. For example, a patient with dementia usually requires 15 different specialists to provide care for them and the family if they are lucky to live in a country that can provide that kind of care. The way we design, therefore, the systems and service delivery and health financing, there are plenty of sessions around those topics matter because that can also shape up what you see at this slide, which is how much we utilize services and how much we use in the way we use health services. There are countries like South Korea with 14 visits per patient per year to outpatients clinics, but there are countries like Malaysia or Sweden with 2.3. South Korea and Sweden, the epidemiological pattern does not differ much, and the service delivery utilization is dramatically different. And this is how we design our systems, and this is how we design the way we use health services. Last point of this presentation is the opportunities for women and for growth, jobs and growth, because we know that care economy and care, long-term care service delivery for elderly people will be a huge demand in terms of workforce. There are 53 million people in Europe currently providing informal care for mostly their family members, and 6.3 there are formal workers. It's a broad term in terms of care, but it's a 3.2% of total workforce. Some countries in Asia, like my own current one, which is Nepal, it's the 3.2, which is formal care providers, is more than all the healthcare combined. So this only shows the magnitude of care economy and jobs, including private sector jobs, to provide all those care that we will need in terms of aging populations. Few lessons or few things to consider for aging countries. This speed that I mentioned at the beginning is much faster than we can imagine. Somebody this week presented some data where they showed that it took France more than 100 years to get to their demographic model that currently they are in. It will take Vietnam 17 years to get to the same place. We don't have time to waste here and discuss and kind of wait for changes to come. Cultural expectations, family care is strong, but then we also see huge changes. Forgetting for a second about conflicts and war, there's migration, smaller families, urbanization. There are huge changes that are imposing on our health systems or service delivery systems those changes that need to take much faster pace. So building formal support, long-term care systems, strengthening primary health care, we've heard about that, new jobs creation, home care, and accelerated by private sector and new technologies is probably a broader look at how we can design our healthcare systems or health and social systems. Last but not least, we all know, as it was already mentioned, we are all public health people here. We all know that health or health systems is only a fraction of influence over our health and longevity. Debatable whether it's 25%, 35%. In any case, it's a small part of what contributes to our health. Nobel Prize winner Professor Blackburn's work showed some years ago that there's something called telomeres. Telomeres are like a short part of DNA, and they can shorten. And if they shorten, then that can contribute to weakened immunity, diseases like cancer, diabetes. And she also did an amazing study on actually people who are providing care for their families, so informal care providers who live for many years in huge stress and in demand for their services, and they have those telomeres shortened. And she proved that by living in continuous stress, poor nutrition, and negative life experiences can shorten telomeres and therefore shorten our life. So stress matters. On the bright side, a study from Sweden presented, I think, last year, showed that social integration has positive relations with slower aging. So these are all my pictures, depending on my lifestyle. Healthcare, broad and fast health system reforms, culture, self-care, and mental health is the way to go in terms of aging populations. So relax, connect, enjoy their discussion. Thank you.
Thank you, everyone. Now it's my pleasure to invite all the speakers on the stage for the panel discussion, please. Meanwhile, I want everyone to scan the QR code. So for people who have already scanned, even without submitting questions, you can just submit, escape, then went to next question, which we're asking, please, if there is one responsive care policy you want to bring home to implement in your country context, what that would be. So please submit that, the answers to that prompt, and we'll have my colleague trying to use the AI to synthesize the answers in the room. Thank you so much. For people who want to ask questions online, in person, so please stand behind the microphone. Please feel free to check. I've already received some questions online, so let me just check. The first question is to Dr. Bishai. So if there are 4 capacities you want to implement in the low resource settings for responsive care, what would be that 4 core capacity in low resource setting?
Thank you for the question about the 4 capacities, and they really come from tools that we already know. We have what we've seen today, which is a needs assessment, which we're already really good at, epidemiology and demography of who is here and what do they need. But add to that what I would call asset-demiology. Epidemiology is the problems that are on the people, but the asset-demiology is the resources that are on the people. And we can learn from our friends in social work that do asset-based community development, where they would partner with the community, making lists of the strengths, lists of exercise groups that are meeting down at the local parks to do Tai Chi, lists of the social workers that are in the community, food banks, YMCAs. Every community has its own asset list, and they are a critical part, because if we want to move into some of these solutions, we would use link workers, community health workers that know the assets and who rely on the assets. So that skill of asset mapping is a core skill in public health. It also subsumes a skill in partnering. You can't do asset mapping alone. You create partnership, creating trust. Being in the room with the community partners is a skill in public health. It's a core skill called community engagement. And then all of our presenters also had an implementation pathway that included watching and learning, and we learned of learning organizations. They didn't just set it up and walk away. They set it up and stayed on the ball, watching it and continuously adapting and learning it. So those would be the 4. Thank you for the question.
Thank you so much, Dr. Bishai. If anyone, feel free to stand up. Another question is for Dr. Tan. How is home-based care financed, considering it may drive up cost and remote nursing care with a ratio of 1-to-1 compared to a hospital setting, where more elective efficiency can be achieved?
Well, this is truly a million-dollar question. Happily for us, I think engaging in extending our care beyond the boundaries of hospitals, we have been able to show some early cost savings. For us in Singapore, creating and building 1 bed costs $2 million. So if you have a 1,000-bed hospital, it costs you $2 billion to build the beds. we don't have enough hospital beds to meet the needs. So some of the examples I've given you about hospital at home, and just creating 40 beds allowed us a bed day save of more than 8,000 days, meaning that we brought in another 1,350 patients onto our hospital who requires acute care. To us, is a cost savings and cost avoidance for the patients. So I think there are economic factors here at play, but I am not at all taking it lightly because it does require fairly long-term, longitudinal assessment and evaluation. Many of the things that we're trying to do today, we are unlikely to see the positive outcome in the next 10, 20 years. And it is not easy to take a business decision now and say we're going to invest for that long forward. That said, the Singapore government has aligned the financing model into a capitation model. And we know now, going forward, we will have what we are historically given to take care of this population that's assigned to us. And beyond that, it will be a inflation-adjusted payment every year. And the health system has to make decisions on what kind of investment they make. And one of those investment that we make is to set up that division of population health and integrated care. Thank you. I hope I answered that question.
Thank you so much. And we have another question on home-based care, I think addressed to both Japan and Malaysia. In home, and of course, other speakers feel free to respond as well. In home-based medical care models, in case of emergency, how do you guarantee the safety and the benefits of medical caregivers since there are no other teams available like in hospitals? I think that's a challenging question. Should I repeat? Maybe Japan can start.
In Japan, the emergency response is covered by health insurance. And there's divided in two processes. One, patient. Second, if we think it needs an emergent visit, we visit patient right away. And all of these are covered by health insurance. So we can get another additional fee according to the time slot. According to this time slot, so if it's at midnight or holidays, we can get another reimbursement. So we can hire a doctor to respond to home care settings. And it's very cheaper compared with ambulance transportation or compared with hospitalization. So now Japanese government strongly promote the home care 24/7 response services to the GPs.
Okay. In Malaysia's case, in terms of emergency, they will have to call the emergency number, which is the 999, and they will get services, or they can call the ambulance to come in. So in that sense, that they will link to the hospital or the clinic that they usually go. That's how it's happened in Malaysia. Yeah. But all these things are all out of pocket.
Great.
Just to add, in some systems, the emergency part is on top of whatever we have at the community level or long-term care. So it doesn't exclude each other. It's just additional.
Great. There's another question about Malaysia. Care in Malaysia for the older adults appears siloed. Is there a plan to develop an integrated long-term care for the older population? Is there political will to invest in healthcare system?
Okay, that's a tricky question for me to answer, but I think there is now initiative for us to do integrated care, because we have piloted, the Ministry of Health has piloted the ICOPE in a state to study how it can be done. And we also have a what you call integrated care for frailty management that integrates the health at the community, at the clinic level with the social services available. And in the sense of political will to integrate, I think there is now the white paper on health, and in that white paper for health, and also in the 13 Malaysia plan, there's a lot of strategies to address aging. And one of them is the long-term care initiatives. And we have also published a policy paper regarding the care economy for us to look into. So I think there is already a political will to look at that, because when you talk about policy development, the last Malaysia plan, we only have a paragraph on aging. But in 2013, in the 13 Malaysia plans, we have several paragraphs in different sectors of the policy. So I think this is a serious matter for the government to consider, and there is hope for us in this matter. Thank you.
Great. We have a very challenging question. I want to maybe Dr. Duma and other speakers, please feel free to jump in. How do countries without enough doctors and nurses to start home-based medical care?
Yeah, thank you very much. It's a very interesting question. I think in our setting, that might be the solution, actually, because you will not have enough doctors to cover the whole population and nurses, and then you need to maybe do some task shifting of those nurses and doctors they do to the community health workers. And I think that will be, to a large extent, solving the problem. Also, we are affected also in the morning session, the migration. So we do produce doctors and nurses, but they are not staying. So that is the other problem that I think we need to take some of those tasks that they do it and shift it to the lower level, so that we can depend on a low level. And I think one of the solutions also to invent a specialty that people cannot migrate. So you can have a 1-year program or 2 years program. In some part of Africa, we have clinical, medical clinicians or something. So 3 years in medicine or in pediatrics or in surgery or so the 3 years, they don't have any option to go anywhere. If they go to Europe, they might not be recognized in the US. So those who will be staying and they will work in the system. And I think those are ways that we need to have a sustainable service in our setting. Thank you.
Yes, I think Sri Lanka also mentioned the low healthcare workers. Then Dr. Madhuwagi, then Dr. Tan. Yeah, if you.
Yeah, when it comes to Sri Lankan setup, actually, we are looking for these sharing resources as well, and cluster model as well, and which is coming under strengthening primary health care. And we have a special category of nursing called public health nursing officers. And also, we are in the process of introducing the telemedicine to the primary health care setup as well, to minimize the shortages of workforce as well. So within that setting up, we are trying hard to do the cluster system as well as knowledge sharing and task sharing as well.
Great, thank you. Dr. Tan?
Maybe 2 quick points. I think many have mentioned here about task shifting. I think the whole concept of micro-privileging, particularly for procedure-based work, it is a viable solution. It is really about what kind of governance that you're able to put in place to offer micro-privileging, rather than to have very broad training, nurse, doctors, which require much longer timeline. You can have a healthcare professional. The other point I want to make, and I think this is where we can be looking at technology to help us solve some of this problem. Truly, the age of having a personal health attendant in the form of an AI-enabled platform, I do not think it is. And in countries where we are struggling with manpower resources, in fact, I would say that even for developed countries with more resources, this is an area that we can look forward to have a solution that is safe, well-governed, and yet at the same time affordable and accessible.
Great, thank you, Dr. Tan. Actually, there is another question for you. How are patients connected to the community partners after hospital discharge? And who is responsible for the process in order to link them to the social prescription?
So as part of the Healthier SG healthcare reform in Singapore, we have divided Singapore into 3 health clusters, and each have given about 1.5 to 1.8 million population to look after. And so, for instance, in my health cluster in SingHealth, we divide our geographical allocations to 15 different precincts. Each precinct has got about between 30 to 50,000 population. And we then what we call Healthier SG group. They are not led by doctors, they are led by community nurse, they are led by well-being coordinators who knows very well the context of the social resources, and we mentioned about this, the social assets that is within the vicinity of where the patient is staying within the community. And what we do then is when the patient is discharged, we connect them to the Healthy SG team, who then connect them to the social organizations that would be able to allow them to benefit from social prescription and therefore hopefully keeping them healthy in the community longer.
Thank you so much. And I also want to ask all the speakers, reflecting in terms of if you have to pick up a couple of the enablers for responsive care, what enablers you would suggesting either financing or aligning incentives with the service delivery or governance regulation. So please, Anna, would you like to start?
Yeah, thanks for the question. I would probably say that the comprehensive and well-connected primary healthcare would be enabled. By well-connected, I mean primary healthcare serving also health prevention functions and connected to hospitalization and acute care, and kind of gathering that these functions are under their integrated or coordinated with other levels of care. Functions would be the enabler that I would see growing more. Thanks.
That's great. Dr. Bishai?
So one story from the UK was based on evidence for prescriptions saved NHS money. Saved NHS money. So both sides of Parliament voted to give government funding to social prescription, and now instead of being a cost, they are a money saver. So in our countries, evidence that what we were doing was saving money, delaying entrance to long-term care, slowing down the burden in the hospitals, that creates money. And it's just a small investment in the evidence that could unlock the market.
I think the sustainability is the most important. In Japan, we have a lot of hospital beds. It is 3 times compared with the average of OECD. We have bed. But in Japan, most of the bed are run by to optimize the healthcare system, a lot of stakeholders. So how to adjust to create a better system is not only the issue. a lot of factors. So I think it is a difficult situation. Yeah, thanks.
Thank you. So please hold the mic to the top. So otherwise it's going to interfere. Yes, like up at the top. Up, yeah. Close to the mic.
I see. Okay.
Thank you.
From my perspective, collaboration is the most important enabler because in order to realize responsive care for older persons, collaboration between patients themselves, families, doctors, nurses, care workers, and other health professionals, and also public health workers and health policy makers are very important. Without daily conversation based on trust, well-designed systems cannot work. So we have to think how we can foster trust and collaboration among multiple professionals.
Great, thank you.
And I think strengthening primary health care is a very effective method that we should think of. And also that is the first contact point for the community to get that service. And also think of the life course approach for early identification and screening parts. Then we can have the better functional ability towards the end of the life course. And also sharing experiences and changing attitudes is a very challengeable thing. Behavioral changes from early years, it needs to be done through the advocacy and the awareness. So all together, it needs to go as a package together. And also multidisciplinary team approach and multi-sectoral collaboration needs to be strengthened and in place. So those are the things that we need to go for better, healthy, aged society.
I think from Malaysia's perspective, the evidence that we need to create to convince the policymakers. I think this is where it is important because we need to pilot those things and then to show them this is cost saving, like what Dr. Bishan said. And many of these examples that I showed are already showing data that we need to move from hospital to the community. But we also, at one juncture, need to train resources. So I like the model of Thailand, where they move into the community and they started training first before they go and implement in the community. So I think, and that will be a model that we should adopt. And another aspect is we are so federal in our decision making, and the people are at the local level. So we need to really do a devolution system so that the local communities or the local authorities would have the initiative to develop services and new services together with the community and the NGOs. Thank you.
Yeah, from my perspective, I think as the example that I mentioned, first we want to embed the community service within the primary service, because the thinking that the primary services stop with the facilities. So we need to extend that understanding. The other thing, we need to bring other actors who can help and sustain this, like community-based organization, NGOs, and if we were successful to bring private sector, that will be the best, so that they can strengthen these community systems to be part of the overall primary health system. Thank you.
Yeah, I agree with what has been said about healthcare financing, whether it's public or private. I also agree with the shift towards the community. I just want to mention maybe two more things, and both are regarding mindsets. One is the mindset of the consumers. In Singapore, certainly there's an overconsumption of specialist services, and that need to change. Secondly, even for the healthcare providers, there is still the thinking that the longer I can save the patient from dying, the better it would be. I think lifespan is best and meaningful only if you have long health span but short sick span. I think this is something that the healthcare professional as a group need to constantly remind ourselves of.
Great. Thank you to all our speakers. So let me just reflect as a moderator, do a very quick summary. Today we started from population needs and from family needs, from people's needs. Then based on the needs, we design the responsive care. As you heard from our panelists, a lot focused on the PHC, primary healthcare, but it's more integrated primary healthcare. It's integrated with the hospital services. It's integrated with the community services. It's integrated with the emergency care, and it's also integrated with the specialist care. So the PHC-centered integrated care with all other components of the healthcare system are essential. Then the challenge becomes up, what are the enablers to design such responsive care? So not just the financing, resource mobilization, aligning incentives with the service delivery, but it's also innovations to have the space for innovative delivery models, but also leveraging digital and other technologies for the innovation. Of course, we heard a lot about government leadership. The regulations, the governance structure has to be in place in order to have such kind of the system. And lastly, as one audience put on there, it needs evidence. It needs lots of the evidence on that. So those are very critical enablers. The last one I want to mention is the human resource for health, the health workforce. We heard a lot about task shifting in Africa region and also in other regions in home-based care, and how we can best use the health workforce and also informal care to enable care. Those are very important. So we learned a lot. I hope that to a certain extent, I summarized a little bit to these very challenging questions. With that, I want to ask audience to give another round of applause to our distinguished speakers and enjoy your lunch. And so lastly, as a moderator, I was asked to emphasize, please evaluate this session and please submit your evaluations to this PMAC. And also you can get a small souvenir after you submitted the evaluation. Thank you so much.